here, so nothing is complicated, just pay attention to it. So let's start with the first case. I will, this is Milan, where I come from. These are old monuments from my city, the Duomo, the castle, the Arco della Pace, the gallery, and the Sant'Ambrogio, which is one of the main church. So if you plan to visit, there's much to see here. But also we have interesting cases, good hospital and good neurologists. And we start from this case called the case B, which has a long presentation because the history starts from the fetal age. We have this fetus, which is 21 weeks of gestation when he comes for the MRI. And the reason for the MRI is that at ultrasound, the gynecologist find a cyst in the left parietal, in the left part of the posterior fossa, with some kind of damage of the cerebellar hemisphere, a cleft of the parenchyma. So we did the MRI at 21 weeks of gestation. This is just to show you that the supratentorial brain is basically normal for a 21 weeks old fetus, but the problem is in the posterior fossa. So here you can see that there is clearly an asymmetry between the two sides of the cerebellum with a kind of a large cystic spaces on the left side, and it looks like that the cerebellar hemisphere is damaged. You can see the small pieces of tissue which are irregular, and but no signs of hemorrhage are detected at this moment. So we conclude on this first MRI that the patient has a dilation of the CSF spaces and a symmetry of cerebellar hemisphere, no signs of hemorrhage, and a normal supratentorial brain. But we are not completely sure about what we are seeing, so we are again, now the situation is a little bit different from what we have seen before. It's not as clear as before that there is a damage of the cerebellar parenchyma. Now that the border, the periphery of the hemisphere looks normal, it looks like the left hemisphere is pushed toward the midline and also a bit crossing the midline toward the right side. And then we have the growth of the cerebellar spaces on that side, but nothing more. So the baby then was born at 36 weeks of gestation with a normal Apgar, normal delivery, and the neurological examination, but something, sorry, a normal neurological examination, but something more interesting comes out when they see the baby, because he has a flat purple stain on his face, on the left hemiface, which is consistent with a capillary malformation. So something that complicates the situation. And then we go to the MRI, the neonatal MRI. And again, the supratentorial brain is normal, no lesion. The signal is normal for a neonate, so no abnormalities. We can see that the vermis is a bit rotated. And then again, you can see what have we already seen in the fetal MRI. We confirm the findings. There is a bit of blood in the along the tentorium, but that is normal for and consistent with the birth and the delivery. But again, here the picture are more similar to the second MRI, where you see the dislocation of the parenchyma of the cerebellum on the from the left to the right side, with the vermis, which is just in a paramedian section lateral to the middle line, mid-sagittal line. We have an enlargement of the CSF spaces, so this is not consistent with a parenchymal damage. At least the measure, it's difficult to measure the volume of the cerebellum here, but we don't see clear signs of loss of parenchyma. So this is on the axion, same things. So the cystic space is enlarged and the appearance of the parenchyma of the cerebellum. Is it everything is done? So just the cystic spaces? Well, actually, if you look better at the images, maybe that some of you have noticed this peculiar sign here, which basically was noted on the postnatal MRI. not during the fetal life. And this is an asymmetry of the Meckel cave. So an enlargement of the Meckel cave on the side of the cystic spaces and the where the cerebellum is pushed. And this is a peculiar sign which should remind you as a specific condition, which is phase syndrome. This paper says that asymmetric Meckel cave enlargement can be detected in up to 76% of patients with phase syndrome. So, has this patient a phase? Well, let's look for other signs. Basically, it maybe some of you also noticed that the peculiar aspect of the cerebellum was consistent with this sign, the tilted telephone receiver sign, which was described by this author, and basically says that the cerebellum is tilted like this, and the enlargement of the CSF spaces pushes the parenchyma upwards and toward the other side of the brain. So two signs which are consistent with the phase syndrome. So we did an MRI angio, and we noticed that there is an asymmetry of the carotid artery, with the left one being a little bit smaller, but not other clear malformation of the vessels. So if you consider the definition of phase, phase stands for P, posterior fossa anomalies, H, hemangioma, arterial lesion, cardiac abnormalities, and coarctation of the aorta, and I, anomalies. So we went to look if the patient had any cardiac abnormalities, and he did not. Just minor findings which are not very consistent with the diagnosis, and the ophthalmologic evaluation was normal. However, if we consider the criteria to define phase syndrome, probably we are between a definite and a possible phase, because the hemangioma was not 5 centimeters, but 4.5. And then we have two main criteria, which are the arterial abnormalities, so the asymmetry of the carotid vessels, and the infratentorial abnormalities with the typical tilted receiver sign, and also the Meckel cave enlargement. So it's a highly probable a phase syndrome, even if it doesn't fit perfectly all the criteria. What happens next? Well, we did a follow-up after 5 months with a quick MRI just to check for the angio. So the parenchyma was okay, nothing happened. If we look at this angio, well, it looks like the carotid is a bit narrower than before. If you compare it with the other one that we did before, it looks like it's a little bit more narrow. However, I must say that the second exam was done with a quick MRI protocol, so the patient was not sedated, and the quality of this MRI angio is a bit lower than the previous one. So we are going to follow up the patient, but probably, well, this is a phase syndrome, and probably you have already noticed that this was in the puzzle. So that sorry, I put chart, but it was a phase. Sorry. And go, Martina.
Okay, so now just to show you a little bit of the city where I live in. So we have, of course, the Atomium, which is a landmark in the center of Brussels, the Grand Place, which is very famous and very beautiful within architecture. They are, of course, headquarters of the European Commission and the NATO, and there are a lot of paintings and art in Brussels, which you can enjoy. So let's move on to the case number 2 with the letter U. So it's the case of a baby who is a little bit preterm and has Down syndrome, and he's born from non-contiguous parents. He has in the prenatal ultrasound an interventricular communication that was seen, and of course, as every baby comes in the NICU with some malformation, they had an ultrasound of the brain and the abdomen, and the neurological examination was unremarkable. So here is the ultrasound, where we can see that there is clearly a deviation to the left from the midline, with a mass effect here from a lesion, which is a little bit hyperechoic. It seems to be intraaxial, and there is no flow at the Doppler ultrasound. So here, the T1 pre-contrast of the brain, where you can see that there is a, I'm sorry, doesn't seem to work. PowerPoint doesn't want to work. I'm sorry about that. That's not good. There is apparently a technical issue. So sorry, I'll have to start again.
Meanwhile, may I ask you something, Filippo? Since we are waiting, are you planning for a formal follow-up for this carotid artery in this patient with a probable or possible face syndrome?
Actually, we could talk to the neurologist, and they say they won't follow up him with the clinically, and probably will do a second MRI at 1 year of age. But for the moment, no.
Great.
Are you still seeing my screen?
Yeah.
Good. I will pass on the videos because it seems that it's complicated for my computer. So sorry about that. So let's see the images from this baby, where you can see that there is a high signal intensity lesion in the right occipital lobe, here where we cannot see anymore the occipital horn of the lateral ventricle. It's high signal on T1. There is no signs of vascular malformation. It is low signal on T2. And which is very interesting to look at is this aspect of geriform aspect, which seems to be the cortex. And there is, of course, the mass effect that we can see. And when we look at the cortex, it seems to be a little bit restricted on the diffusion. Of course, on the susceptibility imaging, there is a low signal, which is concordant with hemorrhagic origin. So in Belgium, we have a lot of architecture, but we have a lot of paints also that are very, very famous, especially in the Flemish part. And of course, here you have a very famous from Magritte, and they have made a very new museum in the city center, which I recommend you to visit. It's very nice. So of course, this baby was operated urgently to drain the hemorrhage for the mass effect. And the post-operative examination was unremarkable. I will try again the video. I'm so sorry if it does not work. It seems it's working. So here you can see that there is a normal ventricular system, and there is a sequela here in the posterior part where the hematoma was lying. I will show you in a bit some images, fixed images. There is some gliosis here in the white matter underneath, and here there is thinning of the cortical ribbon that was underneath the hematoma. Okay, so let's move on to the diagnosis. So it's definitely a hematoma, hemorrhage, but where is it? It's a subpial hemorrhage. So subpial hemorrhage is considered with subarachnoid hemorrhage under the term, so it's a leptomeningeal hemorrhage. And it is often it occurs in preterm and low birth babies. It has a lot of, it's very important because it can produce cortical brain damage, as in our cases. So the subpial space, it's a tight anatomical space between the external border of the pia mater and the internal, it's internally by the glia limitan, it's confined, and it contains collagen, small veins, and inflammatory cells. So here in yellow, you have the glia limitans, and in green, you have the pia mater, and underneath, there is the subpial hemorrhage, where we had the aspect of the cortical ribbon that was pushed by the mass effect. So there are some risk factors, which of course are neonatal babies with neonatal asphyxia or birth injuries, when they have head molding, or if they present with clotting disorder or a venous sinus compression. Of course, in some cases, abusive head trauma can present with this, but it's very rare. So how can we diagnose the location of this hemorrhage is very interesting and important to find where is the cortex lying. So if you see that the cortex is displaced, then it's a subpial hemorrhage. So ultrasound is very accessible and very easy to look at this type of hemorrhage. But of course, if it's peripheral and very small, as it can sometimes be, it's difficult, and you can have a false negative. So MRI, of course, is the examination that can see where the extension and the location of the hemorrhage is. So what's happening is when you have the insult to the glia limitans, then you will have the small vessel, the subPL vessel that will be compressed and stretch and compress. And then you have the blood accumulation in the under the PL matter, and the increase of the PL pressure will obstruct the venous outflow, and this is what will lead to cortical infarction. So I checked on PubMed if there is any correlation between the Down syndrome and this location, but I didn't find anything relevant. So there are different patterns of hemorrhage, subPL hemorrhage. They can be big, they can be small, but what is important to remember is that it can produce a mass effect. So the difference between the subarachnoid and the subPL hemorrhage is the mass effect and the cortical infarction. This is something very important to be aware and to look at. So if it's multifocal, of course, the prognosis is quite poor. And what is important to remind is that it is a poorly recognized type of intracranial hemorrhage because it's very rare, and we have difficulties to see if it's intraaxial or extraaxial if it's very big, and it has a major detrimental effect on cortical integrity. And it's more frequent in neonates and infants, and it has this peculiar imaging pattern, and it's important to know the meningeal anatomy. So here is the hemorrhage, the subPL hemorrhage.
And again, come back to Milan. These are some of the pieces of art that you can find in my city, some very romantic, some very sacred, and some like the finger, a little less romantic. We put it in front of the stock exchange market building just to make it clear what we think about business and finance. So the third case is case D, and again, we start from the fetal life. We have a single fetus, a 20 plus 3 days of gestation. It's a male. We are referred, the patient is referred to do an MRI because at ultrasound, the gynecologist find hydrops, cardiomegaly, ascites, and subcutaneous edema. So these are the findings at ultrasound. In green, you can see the cardiomegaly and some fluid next to the heart. And then in red, you can see the fluid within the abdomen, and also in yellow. And then on the right, you can see the brain, which looks normal. And these findings are consistent for anemia, and in fact, the hemoglobin level of these fetus were very low, 3.1, and also the hematocrit level was 8.4. And when you find such a severe anemia in a fetus, you can think it's an infection, and the infection was found here and was an infection from confirmed by parvovirus B19 infection. And if you have such an anemia, well, the problem is not the infection per se, but the problem is the cardiac decompensation. So the gynecologist decided to do a transfusion, and the fetus was then got a transfusion. These are the findings before on the left. So normal brain when the hematocrit was 8.4 and the hemoglobin level 3. Then he did the transfusion, and the hemoglobin went much better, 14.2, and also the hematocrit increased. But the problem is that the ultrasound revealed some hyperechogenicity in the cerebellum. So they asked us to do an MRI, and we did the MRI. That confirm again the findings that we have seen on the ultrasound. So the fluid collections in the abdomen around the heart, and this the thickening of the subcutaneous soft tissue. But it also, if we look at the brain, confirms some hemorrhage within the posterior fossa again. You can see it here better in this exam. This dark signal attached to the posterior and inferior part of the cerebellum is basically blood, while the supratentorial structure were normal. We decided to make a first follow-up exams at 25 weeks of gestation, and you can see that there is a partial reabsorption of the hemorrhages. They are less dark now, and also the hemisphere are more clearly defined. Maybe there is something missing in the inferior part of the vermis, which is a bad prognostic value. So it seems that the inferior vermis is damaged, but we're gonna see it later because we did a third MRI, fetal MRI at 30 weeks of gestation. And again, now it's much more complex, much harder to see the blood. You can only see a lining, a black lining on the inferior aspect of the cerebellum, and something maybe at the level of the inferior vermis. But then the supratentorial brain is normal, and we have this postnatal MRI that confirm exactly what we have already seen in the fetal MRI. So the signs of hemorrhage are now hard to see. There is an erosion of the inferior part of the vermis, but the hemisphere are pretty normal except for the black lining in the inferior part. How did the kid go? Well, actually, we have a lung follow-up. His IQ is normal, but he has some difficulties. He has dysgraphia, ADHD, and mild dyspraxia. So what is important to think at and to look at the cerebellum when you have an anemic fetus? Because actually it has been demonstrated and shown by many authors now that cerebellar hemorrhage may be a complication for fetal transfusion. So if you have a fetus and the anemic fetus and he undergoes a transfusion, then carefully look at the cerebellum because it can be the preferred site of hemorrhages. And the mechanism for hemorrhage, well, it's probably complicated. Probably there is a contribution both from the infection and anemia and then from the treatment. So the infection and the anemia gives you an increased cerebral blood flow and a reduced oxygen delivery, so an injury of the capillaries, of the germinal matrix of the capillaries. Then you do the transfusion and the blood volume and the viscosity of the blood increase very rapidly, and then you can have an acute venous congestion and reperfusion that can cause the cerebellar hemorrhage. So this may be the cause of the hemorrhages in the cerebellum of fetuses. But why should we treat the anemia? Well, because otherwise the complication of the brain swelling can be even worse. If you don't treat the fetus with a severe anemia, you will find a lot of swelling. So with engorgement of vein, engorgement, sinus dilation, and the parenchyma of the cerebrum becomes white, and you can see on the next images where you have a fetus which is not treated and he has a lot of edema. So you can see the subarachnoid space are very narrow, the brain faces the inner scalp. You can see also in the lower row some hemorrhaging along the ventricles because these are congested veins that goes into rupture, so we can have hemorrhages. So it's necessary to treat severe anemia because you will otherwise undergo these kind of consequences. But be aware that cerebellar hemorrhage may be the result of cerebrovascular changes both during and after the transfusion, and in particular, parvovirus-associated hydropis is related to disability if not treated. So look at the cerebellum when you do a transfusion to your fetus. So, and here was the solution, parvovirus. And the next case is from Martina again.
Okay, so except for painters and nice architecture, we have a lot of comic books in Belgium, especially the first one on the left, which is Tintin in French, with his dog Milou. And they are so proud of this. They have also a plane with this with Tintin on it, and you can maybe have the chance, as I did, to come back to Belgium in this plane, which is blue inside also. So let's move on to case number 4, the letter A. So it is the case of a 5-week-old baby, natural delivery with a good Apgar score. So on the prenatal ultrasound, they found a left kidney hydronephrosis. There was a cardiac malformation and a sacral agenesis. At the birth, they saw an imperforated anus. So let's hope it does not stop. So this is a sagittal T2 weighted images on the spine, where you can see that there is, I will come back on the next slide for the fixed images. I don't want to chat that shit in case it stops. So you can see on the axial plane that there is no dilatation of the ependymal canal, and the conus medullaris will, the medulla will stop at the level of L1. Well, you can see it here, and then there is no more medulla, and of course after this first part of the sacrum there is no more sacrum, there is no coccyx, and he was already operated, of course, for the imperforated anus at the time we did the MR. So this is the aspect, okay? It's abrupt and it's stopped exactly at the lower border of the L1 of the first vertebra. This is the aspect it can take on ultrasound. It seems very difficult, I think, if you're not used to look at this type of region, but you can detect that it is at the lower border of the first lower vertebra. So the brain was normal, and this is the 5-month follow-up where you can see that the left kidney is non-functional, the agenesis is still here, and there is a small dilatation of the ependymal canal. So there are some other findings. Especially there is a fistula between the colon and the bladder that we saw at the fluoroscopic examination. The sacral agenesis and the hydronephrosis was already known. So there are some associated malformation, which are, there is a caudal regression syndrome, there is a sacral agenesis, an anal atresia, there is a fistula between the bladder and the colon, the non-functional left kidney, and there was also a cardiac malformation. So what would be the diagnosis of this case? It's a caudal regression syndrome associated with Bacterl. So a few words about caudal regression syndrome. So it's a spectrum of anomalies where you can have sirenomelia, so it's a mermaid, where there is a fusion of the lower extremities. Here it's a fetus from the literature. You can have lumbosacral agenesis and anal atresia, the external genitalia that can be malformed. That was not the case in our baby. There was no extrophy of the bladder. And of course, the aplasia renals, the renal aplasia was present in our case. And you can have a Potter facies when you have pulmonary hyperplasia, which consists to a prominent infraorbital folds, okay? And it's very rare, this syndrome. So it's a closed dystrophism, and it can be very extensive to only, for example, a segmental coccygeal agenesis, and it is usually sporadic. There is one risk factor, which is pregestational maternal diabetes type 1, and then it's more frequent. So there are two classifications. There is the PAN groups, which determines where the medulla stops. If it's above the lower board of the first lumbar vertebra, then it's a type 1. If it's exactly at the lower board of the L1, then it's a type 2, as in our case. And type 2 of the Renshaw types of the sacral agenesis, in our case, what's a type 2? There was a bilateral partial sacral agenesis. And here are the different parts of the sacral agenesis. It's mild to more severe. So the VACTERL is an acronym and there are vegetable anomalies, anorectal anomalies, cardiac anomalies, the tracheoesophageal fistula, renal anomalies, and lib anomalies. So you need at least 3 components that have to feature, and the most frequent one are the vertebral anomalies, the vertebral defects, are, as in our case, the imperforated anus and the cardiac anomalies, okay? And this is also quite rare. There are, in the literature, they are talking about some chromosomal aberration in this type of cases of patients, and in our cases we did not find any mutation. So the caudal regression syndrome is a closed dystrophism, and it's a multisystemic anomalies, and there are 2 groups. It's important to see if where it stops the medulla. Is it above the lower border of the L1, or is it at the lower border? And in 10% of the cases, it is associated with VACTERL. So it can be either sporadic or hereditary. And here is the VACTERL.
So thank you, Martina. These are more recent architecture that you can find here in Milan. So not only old buildings, and also on the left corner, well, as we don't have a lot of parks here, we decided to put the park in vertical, and we created these things called the Bosco Verticale, vertical forest, which is quite nice, but well, very expensive to live in. But so let's move to case 5, which is case P. And things become a little bit more complicated here because we have a twin pregnancy, a dichorionic diamniotic twin pregnancy that was referred to us after an ultrasound that identified 2 main things: fetal growth restrictions and periventricular lesion, hyperechoic lesions that are underlined by the arrows in blue, which are probably consistent with blood. So we have a parenchymal lesion in the left twin and some clot probably within the ventricle in the right twin. So we did the MRI, and this is the MRI of the first fetus, the left twin. And you can see that there is a lesion, an hemorrhagic lesion within the parenchyma, the frontal lobe. It's quite dark on T2 and a bit bright on the T1 weighted images, and also the diameters of the hemisphere were a bit reduced, so consistent with growth restrictions. The other twin had a different pattern of lesion. You can see that we have a cavitation, already a cavitation of the parenchyma on the left side, some dark signal along the surface of the ventricle, which is consistent with the hemorrhagic hemosiderin, probably. The basal ganglia on that side are already atrophic, rounded, small. And also you can see, if you look quite properly at the brainstem, that there's already some asymmetry in the brainstem. So the left cerebral peduncle is a bit smaller than the right one. So kind of a Wallerian degeneration that reduced the volume of this peduncle. What to think in this situation? So we have a condition where we have isolated parenchymal hemorrhages. Okay. But we don't have any signs of infections or any signs of anemia, as we have seen before, heart failure, or twin-to-twin transfusion syndrome. So it looks like something different, probably a genetic condition. Well, we suggested the gynecologist to look for a specific gene, a specific mutation in this gene, which is called COL4A1 gene, and actually the results arrived after birth, but those twins were mutated for COL4A1 gene, and we will see in a bit what does it mean. This is the follow-up scan for the left twin at 3 weeks of age. So you can see that now the hemorrhage turned into a cavitation, and also you can see some lesion on the other hemisphere in the T1 weighted images on the right. The bright spot, probably new hemorrhages that that appeared, while the brainstem is symmetric in this case. The other twin shows what we have seen previously. So in the fetal life, again, we have the cavitation of the frontal parenchyma, we have the asymmetry of the brainstem, which is confirmed also at the level of the pons, and we have some hemosiderin residual within the parenchyma. We then did a follow-up MRI at 3 years of age, and now what you can see better is the gliosis around the ventricles at the level of the superior part of the white matter, centrosemiovalis, because of the maturation of the myelin that makes these signs more easy to detect when the myelination is concluded. And also you have a thinning of the corpus callosum secondary to the loss of parenchyma. And then in the other twin, same findings. Again, now you see the gliosis, which wasn't so clear in the first exams. So a big damage, which is also demonstrated here by the DTI, the color map of the DTI, with the loss of of the blue part related to the corticospinal tract, because this twin actually had a hemi syndrome while the other one had not. So, and this is also consistent with the asymmetry that we have noticed in the breast. So this is the evolution of the lesion. So the hemorrhage, then the cavitation and the gliosis. And again, in the second twin, we already have the damage, the parenchymal cavitation with reduction of the basal ganglia and then the gliosis. So this is maybe straightforward and easy, but sometimes you don't have the fetal exams and you only have this situation where you can see only the results of the damage. And if the neonatal history is normal, if there is no history of infection or something suggestive for other causes, maybe you can find an hemorrhage related to COL4A1 mutation. What is this gene? This gene is involved sorry, is a gene involved in the production of collagen type 4, which is expressed at the level of the basal membrane of the of the vessel. So when you have a weak a damage in the collagen, also the vessel become very weak and hemorrhages are more frequent. The mutation can be dominant or recessive, but in 60% of the case we have de novo mutation. And the involvement can be very heterogeneous. So sometimes you have multi-organ involvement, but sometimes you can only have the brain pattern with hemorrhages. So don't miss this diagnosis or think at it. This is where the basal membrane is located and where the damage takes is. So you can see in the middle figure, you can see on the left a control neonates, and on the right a patient with a mutation, and you see the thickening of the basal membrane and the derangement of its structure. So this gene is one of the most frequent cause of monogenic cause of congenital small vessel disease with these kind of damages, and COL4A1, COL4A2 are frequently responsible for hemorrhagic lesion. But remember, also you can also have porencephalic areas, calcification, or malformation of cortical development if the lesion occurs in a very early stage of the pregnancy and of the brain development. So finally, when you should think at COL4A1 gene, well, basically, or A2, when you have an intracranial hemorrhage or porencephaly in a term-born or in a fetus, and when you have excluded any other causes, and in particular you don't have a thrombocytopenia. Look at the last row there. You can see a patient with a very massive damage, which was detected after life. So the scan is at 6 days of gestation, but the damage had a prenatal onset, so it occurred before. And it can be just one shot. You can just have one event in your life, and then that's it. But the damage can be very, very, very bad, as you can see here. So COL4A1 was in the puzzle. Again.
Okay, thank you, Filippo. So let's go back to Belgium, where we love to eat and drink, and of course, you know that we are very proud of our fries, potato fries, the mussels. We have a lot of beers, more than 100. Chocolate is very famous in Belgium, and of course, there are sweets like waffles and dame blanche. So let's move on to case number 6, letter E. So it's a child, 1 day old, it's a girl. We're coming inside where we perform a brain ultrasound because there was a polymorphomative syndrome. So here we can observe that there is a little bit dilatation of the ventricular system, and maybe, as if we look correctly, the corpus callosum, it's a bit shortened and a bit thinned at the posterior part. So they performed an X-ray where we can observe many things. So there are many malformations here. There are no sutures seen, at least not all of the sutures I've seen. There is a proptosis here of the eyeball. There is a mid-face hypoplasia. So there are many things to work up on the CT and on MR. So 3 days later, after birth, we did an MR where we can see that there is brachycephaly. So the anterior posterior axis is shortened. The posterior fossa is very small, and the cerebellum tends to ptosis inside the foramen magnum, and the brainstem is a bit pushed anteriorly because of the small posterior fossa. So here, the VRT reconstruction, when you see the baby, the proptosis is quite marked, and the forehead is very big. And on the bones, sorry, you can see a very, very large anterior fontanelle. There are some aspect of defects, thinning of the skull, and of course the hypoplasia of the maxillary bone and a big forehead. So 6 weeks later, the patient started presenting with a bigger perimeter of the head. So we performed the CT, and we see that there is hydrocephalus that has appeared. So at 10 weeks, we did an MR where we can see that there is even worsening of the hydrocephalus without any sign of periventricular resorption. Okay, so, and the posterior fossa is still very small, and the cerebellum seems to go further down in the foramen magnum, as you can see here in the axial plane. now. So in 9 weeks, the hydrocephalus appeared, and he was treated with a shunt. She was treated with a shunt to decrease the intracranial pressure. So what is very interesting in this case, that you have the an enlargement here at the mid skull base, giving the aspect in the coronal plane as a clover leaf in the shape of the skull. And there are also here in the defects, in the bone defects, some encephalocele of the brain parenchyma. Sorry. So this patient is almost 8 years old, and here is the skull now, where you can see that there are no suture anymore. Of course, they are all closed. The forehead is very big. The mid face is very small. The maxilla also is hypoplastic, and also the external auditory canal is very small, and it's narrowed. So what should be the diagnosis? Once you see it, you never forget it. It's a Pfeiffer syndrome. This one is a type 2. So Pfeiffer syndrome is a type 5 acrocephalosyndactylia, and it's the second most common acrocephalosyndactylia after the Alport syndrome. It's an inherited craniofacial disorder. You can have families, everybody with a Pfeiffer syndrome. So it's a syndromic craniosynostosis, and it is called oxycephaly or turicephaly. It means that all the sutures prematurely close. The midface is hypoplastic, and of course, as you can see here in our patient, there are limb anomalies. Here you can see the syndactyly between the second and the third digit, and you can also have polydactylia and enlarged thumb and the great toe. The stenosis of the external auditory canal we also had. I'm sorry. So the premature closure of the coronal and the lambdoid suture gives this clover leaf appearance of the skull. The skull base is hypoplastic, especially in the mid part, and you have a reduced intracranial volume. And of course, what happens? The intracranial pressure will increase. So there are 3 types of Pfeiffer syndrome. You have the type 1, which is the less severe, and it's the classic one, where the child presents with brachycephaly, the maxillary is hypoplastic, they have hyperteluriums, as you can see here on the picture, and of course, proptosis of the eyeballs. They also have limb anomalies, and they can present with a normal intelligence. Our type of patient, of course, it's not so much pronounced, but they present with a clover leaf skull appearance, and they have very poor prognosis because the brain cannot develop correctly. They are associated with hydrocephalus, and they also have this peculiar aspect of the midface, and the ears and the eyes are also displaced because of this hypoplasia. Neurologically speaking, they are limited in the development, and they also present with visceral abnormalities. And the type 3 Pfeiffer syndrome also have craniosynostosis and also a severe proptosis. It's sporadic and it has poor prognosis. They present with the same symptoms as are the type 2, but they don't have the cloveleaf skull deformity. So they also have a short anterior cranial fossa base, and they have proptosis, of course, and different visceral abnormalities. So neurologically, they are also limited in their development, and they can also have seizure after birth. So this syndrome is linked to a mutation of the fibroblast growth factor receptor, type 1 and 2, and the most frequent is the type 2. And in 20% of the cases, as in our case, you don't find any mutation. So the inheritance is dominant, and of course, it's quite rare. So there are some complications to be aware of linked to the reduced brain development. The mental status is subnormal. They can have aspiration pneumonia, and of course, because of the proptosis, they will have ulcer of the cornea and erosions. Seizure and obstructive sleep apnea can also be present. So Pfeiffer syndrome, it's a syndrome very peculiar. When you see it, you don't forget it. It's a type 5 acrocephalosyndactylia, and the diagnostic clues are facial bone, maldevelopment, and brachysyndactyly. So in type 2, there is the cloverleaf skull appearance, and they have also broad toes and visceral anomalies. And the type 3, it's like the type 2, without the cloverleaf appearance, okay? And the inheritance is autosomal dominant. And this is the diagnosis, Pfeiffer syndrome.
So thank you. Before moving to my last case, let me say that Milan is not only buildings and art, we have much more. We have food, of course, we have sport, we have fashion, we have design. And remember that we are going to be an Olympic city in 2026, hosting the Winter Olympics with the Cortina. But then let's move to the last case, my last case. Case 7, case S. Again, we start from fetal life. We have a fetus of 30 weeks of gestation. It's a second pregnancy for this woman. She had a previous miscarriage. And the ultrasound findings are quite unspecific. They say that the fetus has a unilateral ventriculomegaly, so nothing, so not very severe, but he has a midline shift at the level of the frontal horn. So we do the MRI, and these are, sorry for the quality of this image, but I put on the right and with a green border the normal appearance of a fetus of the same age. Comparison, you can see here that the corpus callosum is a bit short, but then let's look at the other images. So we go to the axial one, and again you have in the top row the abnormal fetus and in the lower row the normal one. And if you compare it, you can see first that there is an asymmetry of the Sylvian fissure. The Sylvian fissure are quite irregular in our fetus, narrow on one side, while in the normal fetus they are wider, well designed. Here they are incomplete and irregular. Also the basal ganglia are a bit abnormal. You cannot see a clear differentiation between the caudate and the other nuclei, so something is wrong also at the level of the basal ganglia. If we look at the coronal sections, again same findings. So you can see that there is, of course, there is a ventriculomegaly, but the problem is not the ventriculomegaly, but is the asymmetry in the gyrification and in the shape of the Sylvian fissure, which is quite unusual in this case. So we have a bunch of abnormality: brachycephaly, unilateral ventriculomegaly, dysmorphism of the Sylvian fissure, and the thin corpus callosum. These are clue for something. Well, of course, this is a malformed fetus, but let's see what happens after life, after birth. The patient had a developmental delay, language impairment, and epilepsy, of course, and this is his postnatal MRI at 1 year of age. First, you can notice that the corpus callosum is clearly abnormal. Here is more easy to see, but well, it's not only thin, but it also has an irregular shape. But something else is abnormal. The anterior commissure is missing, or is very, very thin. So we have abnormalities of the commissures. First element. And these are the arrows pointing at the corpus callosum and the anterior commissure. Then we have other abnormalities that we have noticed on the fetal MRI, the basal ganglia. So you cannot see properly the anterior limb of the internal capsule, especially on the left side. And also the thalami are a bit rounded, less elongated than expected. So we have basal ganglia and thalamic abnormalities. So 2 elements. Then we have something more. Again, look at the cortex. We have many abnormalities here. We have some dysgeric cortex in the posterior part, so in the occipital part of the brain on the right side. But also we have a narrow, the Sylvian fissure, where we notice the abnormalities in the fetal is irregular. It looks like there is a kind of a polymicrogyric cortex at the level of the posterior operculum. So we have a cortical malformation. So 3 elements still. Well, this should be enough to make the diagnosis, but if we look better, we see something more. There is a mild, in this case, mild asymmetry at the level of the brainstem, in particular at the level of the pons, with a mild minor pons on the left side and mild smaller cerebral peduncle on the left side. But in this case, I must say that this is quite smooth and very tiny finding. In some cases, it could be very much more evident. this fetus, this kid could have something more, could have also an abnormality of the cerebellar cortex that he doesn't have, so a cerebellar dysplasia. And if you put all these elements together, these 5 elements, combining them as you like, you can come up with the diagnosis and suspect the diagnosis, which is in this case a tubulinopathy, so a mutation in a tubulin genes. And actually the patient was tested positive for a mutation in TUB-A1A gene. So just to quickly say what tubulinopathies are, you know that tubulin genes encode for proteins which are fundamental for the structure of the microtubule. So they are the bricks that makes the microtubule. So, and they are involved in many processes during the development of the brain, from proliferation, but also migration and cortical organization. So a defect, a mutation in this gene has a tremendous impact on the shape and the development of the brain. Typically, the patient can have a very complex pattern of symptoms, from epilepsy, cognitive impairment for sure, abnormality of the movement of the eyes related to atrophy of nerves, so in particular in 2BB2B and 2BB3 genes, but also other conditions like auditory dysfunction, cyclic vomiting, and so on. So very complex patients with the development delay as a main finding. Just to reassure, remember the 5 things that you should consider in these cases and that can suggest you the diagnosis. The commissural anomalies, you can see how our patients, a group of patients that we described, so how different can be the abnormalities of the commissures, corpus callosum and the anterior commissure. Then you have the basal ganglia. Again, 5 different patients with the mutation in tubulin genes, and look the absence of the anterior lip of internal capsules and around the thalami. Then the cortical abnormalities, and again, many different patterns can be present. So schizencephaly, polymicrogyra, double cortex, dysgyra or heterotopia. So many different patients, many different cortical abnormalities can be present in the different patients we have. And more recent findings, we went to look at the infratentorial brain, and you can find cerebellar cortical dysplasia, which is typically affecting the posterior and inferior part of the hemisphere, and usually it's more frequently unilateral than bilateral, but whatever, it can be also bilateral. And finally, the asymmetry of the abnormality of the brainstem, typically asymmetry of the brainstem, cleft, anterior cleft, that you can see, for example, in the 3rd row here in our series. And if you do a fiber tract tractography, you can see a complete derangement and reorganization of white matter blue tracts that and red tracts corresponding to transverse pontine fibers and corticospinal and ascending tracts, which are completely messed up. I didn't put the image here, but if you do tractography, you will see. So commissural anomaly, basal ganglia again, and thalamic cortical malformation, brainstem asymmetry, and cerebral dysplasia should suggest you, should remind you of a tubulinopathy, and you should look for this kind of gene and make the diagnosis if possible. Our fetus had most of this finding. This is just to sum up what we have seen before and after birth, and basically, well, actually, it's easier to see them on the postnatal MRI, but most of the findings were there also in the prenatal exam. So that was my last case, and tubulin was in the puzzle again. And now I think that is just the last case from Martina.
Okay, before moving on to the last case, so in Belgium, we have a lot of rain, but we like to eat, to drink, to party. So if in case you are interested in coming to a festival, this in July, you have Tomorrowland, maybe you know. So they like planes, and they also put this mascot for Tomorrowland, where they people party and coming from all over the world already. And if you buy the ticket, you will find this box this year. When you open it, you have these beautiful, gorgeous flowers. So it's very expensive festival. It's very nice. And you can see this setting, which is very beautiful, the decor amazing, and you can also party. And I think you don't have the sun, but it's normal, but you can have dance and have the sunset to look at the stage. So we don't only have electric music, we also have metal meetings. I was there this weekend, and there was mud all over the place because it was pouring rain, as it is now in Italy. And it was very difficult to even walk and everybody had booths to walk for, and you have the scene there. And I discovered what crowd surfing is. This is me, I hope it works, with my brother and sister-in-law. And actually people go above the other people and they surf on us. So it's quite dangerous, but it was quite fun. So let's move to the last case of the presentation, which is case number 8 and the letter T. So it was a 13-year-old boy who was referred for an hemorrhagic shock, and he was completely unconscious in the puddle of blood in his bathroom floor. And what happened is that he fought with his brother. He was very tall, I remember him, and he passed through the glass door of the shower, but it was not a secure one. It was a very old shower and the one that breaks if you pass through. So he had a lot of blood loss, and it was estimated to 1.5 liter. And he had, of course, he was being transfused. So he was very unstable. The systolic tension was at 14 millimeters of mercury, and there he had a left axillary wound. There were no other visible wounds whatsoever, and he managed to arrive to the CT scan, and we did a total body CT scan. So here is the axial non-contrast brain CT showing no hemorrhagic components intraaxial or extraaxial that could explain this volume loss, this clinical status. And when you do the angio CT, well, the images are a bit of low quality, but it's an old case in 2016, and the CT was a bit older. And you can see the supra-aortic vessels here. You have the look at this part here, the vertebral artery, the third portion here, and I will stop it and go back again on it. There is a wound. It seems what to be a wound here. You see the skin is, there is a lesion on the skin. There is a hematoma inside the muscles. And when you look at the third portion of the, oh my God, I think it's going to crash. I'm not touching it anymore. Let's go to the next slide. It was a very bad idea to put videos on it. I'm really sorry about that. I will see if I can make it work.
Yes, again. So I can make another question. So we take advantage of this little break. There is a question from Dr. Rebo for Filippo regarding the patients with COL4A1 gene variants. He is asking any motor deficits in the course of their development. Remember the cases of the two twins?
Motor, you asked.
He's asking if those patients eventually developed any motor deficits along the course of their life.
Yeah, yes. The second one, the right twin, the one with the basal ganglia, which was already affected during fetal life, had an Hemi syndrome. The other one did not. And also DTI, I put only the DTI of the second twin, which had a atrophy of the brainstem, what was consistent with the side of the hemiparesis. The other one had only cognitive impairment, developmental delay. The second one had also motor impairment, yes.
Great, thank you.
Okay, I'm so sorry about this. So let's move on to the images. So we can see that there is a hypodensity inside the vertebral artery here in this left side, and there is extravasation of contrast. So when I said this to the colleague in the emergency department, he did not believe me because it was a very small finding. And I said, yes, he's losing blood from there. He has to be transferred. And so they listened to me, and they transferred him because there was not anywhere else any hemorrhage that was found. So they transferred him for the angiography in the other hospital because we don't have in the children's hospital. And what he found the dissection of the artery. There is a pseudaneurysm here, and there is a small reduction of the lumen, of the natural lumen, of course. So what he did, the radiologist, he analyzed this dissection and the pseudaneurysm, and there was a retrograde flux of revascularization from the contralateral vertebral artery. So here are the post-operative images. So unfortunately, when he woke up, he presented with blindness. So I'm not touching the video because I want to make the system crash. So here are the images where you can see that there are multifocal hypodensity in the posterior vascular territory of the supra and infratentorial regions. So he had an ischemic stroke because he embolized from the dissection. So unfortunately, he woke up blind, but fortunately, he recovered his blindness. There are some ischemic lesion in the posterior part here, as you can see in the occipital lobes in the left cerebellar part. And all of these lesions, of course, now are sequelar, but he has recovered his sight. And as you can see here, there is a stop between at the third part of the third portion of the vertebral artery treatment. So he was only left with the left homonymous hemianopsia. This is how he sees now on this depicted image, but he is not more blind anymore. So this was all because a fight with his brother. So what is the diagnosis? So it's a complicated post-traumatic with a blunt trauma, vertebral artery dissection in a 13-year-old child. So strokes in children are in 30% of the cases, they occur in the posterior circulation, but when it's secondary to vertebral artery dissection, it's actually very rare. And here is a traumatic one. Usually it's a fall, or now here it's a blunt trauma. It's rarer in children than in adults. So this is the location of dissection in our case, and he had this posterior ischemic stroke in the posterior territory. So what happens is you have a dissection of blood throughout the defect in the intima layer, and there is an intramolar hematoma. There is a fault channel between the intima and the muscularis, and then this intramolar thrombus may embolize. If you have a dissection of blood in the muscularis, then there is a pseudaneurysm. In this case, we had both. So it usually occurs around the C1, C2 level because it's the most mobile part. The gold standard, of course, is cerebral angiography, but when the patient is unstable, you go to angio-CT, and it's very, very sensitive to detect the thrombus, the intramolar thrombus, the flap, not in our case because the CT scan was very old, and also MR is very sensitive, but of course in acute setting it's not indicated. So there are some risk factors, but here in this case, since it was a traumatic, he didn't have any. And of course, since there is you can have multiple infarct at the presentation, which are associated with the dissection of the vertebral artery. So this patient needs to have a systemic anticoagulation to avoid these ischemic brain lesions. And of course, when they are hemodynamic unstable, they have to be treated. So it is very typical feature here. It was very difficult because you had the patient that was very unstable for a very, very small lesion. He didn't have a big hematoma. So it was a very difficult case. And it is more frequent in the C1, C2 level because it's a more mobile location of the craniocervical junction, and of course they have to be treated to prevent emboli and stroke, and embolization has to be performed when they are unstable. So here is the last one of the diagnosis. Filippo.
Yeah, thank you, Martina. And probably our audience didn't pay attention, but we put kind of a subliminal message in our discussion. If you have heard, we named the case BUDAPEST, and in the last, the puzzle, there is also Budapest as word. So don't miss the Congress in Budapest. It will be a great occasion to meet together and to discuss about neonatal, fetal, and postnatal cases. So don't miss the first Congress in Budapest. And I hope that the subliminal message worked and you're going to subscribe so soon. And let me finally thank the people that work with me and helped me to put together the cases, especially Cecilia and Chiara, who work with me at the Buzzi Hospital and helped me with the presentation of the hemorrhagic cases, but also Andrea and Jana.
I would like also to thank all of my colleagues in the Children's Hospital, which I say hello to. Thank you, and I'm sorry about the crash.
I want to thank you too for the astonishing presentation. I learned a lot, and the cases are very nice. And thank you, Sabina, for organizing it. And see you in September, I think.
Yes, actually, we don't have further questions. I wonder if someone who was shy, a little shy during the talk has the last possibility now, couple of minutes. Otherwise, actually, we did even well and in advance. You were super fast and you presented very interesting cases. I liked them a lot. Yeah, no further question coming. So, yeah, see you next season. So, and congratulations, guys. It was excellent.
Thank you.
Bye
See you,
bye.
everyone. Hope you enjoyed.
Bye.
Great, bravi, bravi. Come si fa?